Good morning, I'm Dr. Ranjan. I'm starting with my new lecture today, that is periodontal indices, that falls under the chapter dental epidemiological indices. Here I will discuss about periodontal index and also CPI, that is community periodontal index. So it all comes under community periodontal, it all comes under periodontal indices. So there are first thing we must know what index definition is. So an index has been defined as a numerical value describing the relative status of a population on a graduated scale with definite upper and lower limits, which is designed to permit and facilitate comparison with other population classified by same criteria and methods. Now, this definition was given by Russell Hale and in the year 1969. In other words, to understand an index is an expression of clinical observation in numerical values. So objectives of an index, if we talk about objectives, one of the most important objectives of an index is to increase your understanding of disease process, thereby leading to methods of control and prevention of disease. So what would be the purpose and what would be the use of objectives? Because if there is an objective, there must be some purpose. And what purpose there would be? A few of them. An index, it can provide individual assessment to help a patient recognize an oral problem. It may also help in revealing the degree of effectiveness of present oral hygiene practices, and because it will provide individual assessment to help a patient recognize an oral problem and effectiveness of hygiene practices, both mechanical and chemical, that may lead to the motivation of the person in preventive and professional care for elimination and control of oral diseases. It will help in the evaluation of success of individual and professional treatment over a period of time by comparing index scores. It will provide a means for personal assessment by the dental hygienist of abilities to educate and motivate individual patients. So there are various indices that is used for assessment of periodontal disease, various periodontal diseases. First of all, you must know what includes periodontal disease related areas. Periodontal disease is a term which includes all pathological conditions of periodontium. Those contains gingiva, cementum, periodontal fibers in alveolar bone. So it is a major oral disorder of universal occurrence as it is affected by age, gender, ethnicity, income, social class, and educational status. status. Okay, and it is a social disease. You may contain, you may consider it as a social disease. So Pudendal Index of PI. It was developed by Russell Hale in 1956. Pudendal Index was intended to estimate deeper periodontal disease by measuring the presence or absence of gingival inflammation and its severity of pocket formation and masticatory function. The scale of value for PI ranges from 0 to 8 with increasing prevalence and severity of disease. It is useful among large population but of limited use for individual or small groups. PI is most widely used periodontal index in epidemiological survey around the world. It is a composite index. Why composite? Because it records both the reversible changes due to gingivitis and more destructive and presumably irreversible damage brought by deeper periodontal disease. So, what is the method to perform record this periodontal index? All the teeth present are examined. All the gingival tissue circumscribing a tooth is assessed for gingival inflammation and periodontal involvement. What would be the scoring criteria? So the Russell, now here Russell chose the scoring value 0, 1, 2, 6, 8, 3, 4, 5 and 7 are missing in order to relate the stages of the disease in an epidemiological survey to the clinical condition observed. Now there is one Russell's rule. Russell's rule is if you are in doubt, assign the lowest score. Okay, when in doubt, assign the lower score. Now calculation. How it is calculated? The periodontal index score, PI score, as per individual is obtained by adding all the individual score and dividing it by the number of teeth present or examined. So the periodontal index per person would be sum of individual score and it is divided by the number of teeth present. Drawback of periodontal index. There are few drawbacks also. Since only one mouth mirror and no calibrated probe or radiographs are used when performing periodontal index, examinants, the result tends to underestimate the true level of periodontal ligament disease, especially early bone loss in a population without obvious supragingival calculus is also underestimate in periodontal index. There are few uses also. It is used in epidemiological survey. More data can be assembled using periodontal index than any other index of periodontal ligament diseases. It is used in national health survey in the United States. So here is a table to describe the group periodontal index scores and clinical manifestation. If you see the clinically normal supportive tissue of group that is 0 to 0.2, there will be no stage of diseases it is neither reversible nor irreversible. If there is simple gingivitis, the score would be of group 0.3 to 0.9 is there. It is also in either not reversible or irreversible. But the beginning of destructive periodontal ligament disease has a score of 0.7 to 1.9, that is reversible. And again, established destructive periodontal ligament disease score is 1.6 to 5.0, that is here irreversible. And the terminal disease score is 3.8 to 8.0, that is again irreversible. If we talk about individual periodontal disease index score and clinical condition, that would be clinically normal supportive tissue if individual score is zero point 0.2 up to 0.2 from 0 to 0.2. Now, simple gingivitis is established where the score is 0.3 to 0.9, 0.3 to 0.9. And we can say the beginning destructive periodontal disease is there present when the score is 1.0 to 1.9. And established destructive periodontal disease has a score of 2.0 to 4.9. And the terminal disease, we say when the score is 5.0 to 8.0. Now there comes one gingival bone count index. This was developed by Janine Jem and Leach LB in 1960. The gingival bone count index records conditions and level of crest of the alveolar bone. This index permits differential recording of both gingival and bone conditions. The bone level is assessed by clinical examination, but radiographs are recommended for greater accuracy. Subjective measurements of gingivitis is made on an arbitrary scale of 0 to 3 for each tooth, and proportionate measurements of bone loss is made on a 0 to 5 scale. Now the scoring criteria, if we talk about scoring criteria, GB, gingival bone count index is recorded according to the following criteria. So the gingival score, one score is assigned to each tooth studied and a mean is computed for the whole mouth. If 0, that is negative or no gingivitis, and 1 is mild gingivitis involving pre-gingival margin, fibula or both. Then 2, moderate gingivitis involving both free and attached gingiva. 3, severe gingivitis with large and easy hemorrhages. Then bone score or bone loss. 1 score is assigned to each tooth studied visually or by X-ray, and mean is computed for whole mouth. So criteria and score. If the score is 0, it means there is no bone loss. Score is 1, it means it's incipient bone loss or notching of alveolar crest. If the score is 2, means bone loss approximating 1/4 of root length or pocket formation one side, not over 1/2 of root length. If score is 3, bone loss approximating 1/2 of root length or pocket formation not over 3/4 root length, and the mobility is slight. If the score is 4, it means bone loss approaching 3/4 of root length or pocket formation one side to apex. It means mobility is moderate. And if the score is 5, it means bone loss completely and mobility is marked. Complete mobility is marked. Now, if we talk about one more Community periodontal index. Next is about the next index, community periodontal index of treatment needs, or we also say short CPI-TN. It was developed in 1982 by a joint working committee of FBI and WHO. The members were Jukka Enamo, David Barnes, George Bigri, Terry Cuttress, John Martin, and Jennifer Sardo Inferi. So this index is being recorded with the help of CPITN probe, and the index was developed by primarily to survey. The index was primarily developed to survey and evaluate periodontal treatment needs rather than determining past and present periodontal status. That is recession of gingival margin and alveolar bone. What is the scope and purpose of this index? This is recommended for epidemiological survey of periodontal health. It provides guidance on planning and monitoring of the effectiveness of periodontal care programs. It uses clinical parameters and criteria relevant to planning for the prevention and control of periodontal diseases. It records the common treatable condition, namely periodontal pockets, gingival inflammation, dental calculus and plaque retentive factors. It does not record irreversible changes such as recession or other deviations from periodontal health such as tooth mobility or loss of periodontal attachment. So it has few advantages also. It is simple to use and has international uniformity along with rapidness. Means it has a quality of simplicity. It has international uniformity and it has speed. There are few limitations of this index. That partial recording, exclusion of some important signs of periodontal breakdown notably. It has attachment loss and absence of any marker of disease activity or susceptibility. Means it does not help in the recording of past periodontal breakdown, and it does not help in recording of small gingival shapes also. Now, what would be the procedure of CPITN? The dentition is divided into 6 parts or sextants, 6 sextants for assessment of periodontal treatment disease and periodontal treatment needs, and each sextant is given a score. For epidemiological purpose, the score is identified by examination of specified index teeth. For clinical practice, the highest score in each sextant is identified after examination of all teeth. The score is 0, it means there is no need of care. Score 1, that is bleeding gingiva or gentle probing. If there is 2, score 2 means pressure of plaque and other plaque retentive factors. Score 3 means presence of 4 or 5 mm pocket. And the score 4 means presence of 6 mm of deeper pockets. Sextants in which the mouth is divided, those are 6, that is defined by the tooth number. That is 17214, 13223, 24227, and again 34237, 33243, and 44247. Third molars are not included except for where they are functionally in place of second molars. The treatment need in sextant is recorded only if there are 2 or more teeth are present and not indicated for extraction. When only one tooth is remain in a sextant, it is included in the adjacent sextant. So index teeth, the recording per sextant are based on findings from a specified index teeth. In epidemiological survey for adult aged 20 years or more, only 10 teeth known as index teeth are examined. The examined teeth are for the age of 20 years. In epidemiological, the recording per sextant are based on findings from specified index teeth. Here you should know that in epidemiological survey for adult aged 20 years or more, only 10 teeth known as index teeth are examined. And below 19 up to 19 years, only 8 teeth are examined. So here up to age of 20, second molar, first molar, or say 1716, central incisor 11, first quadrant central incisor, then 26, 27, then 37, 36, 31, 43, and 47. The molars are examined in pairs and only one is scored. The highest in is recorded, only one score is recorded for each sextant. For younger people up to 19 years, only 6 index teeth are examined. The record molar are recorded and the molar are excluded as index teeth at these ages because of the high frequency of false or pseudo pockets or non-inflammatory associated with tooth exception pockets. The 6 teeth selected are 16, 11, 26, 36, 31, and 46. All teeth in a sextant are examined. When examining children less than 15 years, pockets are not recorded, although probing for bleeding and calculus are carried out as a routine. The WHO periodontal examination probe, or the CPITN probe, it was first described by WHO, also known as TRA 621. This probe was described by WHO in 1978. The pocket depth is measured through color coding with a black mark starting at 3.5 mm and ending at 5.5 mm. And the probe has a ball tip of 0.5 mm diameter that allows easy detection of subgingival calculus. A variant of this basic probe has two additional lines at 8.5 mm and 11.5 mm from the working tip. The additional lines may be used when performing a detailed assessment and recording a treatment plan for a complex periodontal therapy. The probing procedure: a tooth is probed to determine pocket depth and to detect gingival calculus and bleeding response. The probing force can be divided into a working component to determine pocket depth and a sensing component to detect subgingival calculus. The working force should not be more than 20 grams. A practical test for establishment for this force is to gently insert the probe point under the bigger nail without causing pain or discomfort. There are various codes and criteria. Code 0 means no periodontal disease or healthy periodontium. Code 1 means bleeding observed during or after probing. Code 2 is calculus or other plaque retentive factors either seen or felt during probing. Code 3 is pathological pocket 4 to 5 mm in depth gingival margin situated on black band or probe. Code 4 is pathological pocket 6 mm deep or more in depth, black band or probe is not visible. The examination procedure is to determine the highest score applicable to each sextant with less number of measurement. There is an explanation for this clinical criteria. Bleeding or gentle probing of plaque retentive factors, calculus or overhangs of restoration. So 4 or 5 mm and 6 mm or deeper pockets are basic indicator for treatment need. Bleeding is an early sign of disease which can be overcome by self-care, following suitable oral health education and instructions. Self-care is prerequisite for all periodontal therapy. This treatment is recognized as treatment need 1. Now, calculus and other plaque retentive factors favors plaque retention and inflammation. Unlike plaque, calculus needs a professional care defined as treatment need 2. For patients with deep pockets, even after scaling, root planning, and control of bleeding by hygiene, there will generally be residual pockets. The treatment of these conditions may require complex therapy for which clinically trained and experienced dental personnel are needed, and it is recognized as treatment need 3. Calculation of CPITN for population can be done as follows. So, step 1, count the number of charts with different codes and add up the codes individually, that is codes 0, 1, 2, 3, 4. Step 2 is to obtain the prevalence percentage of subjects with codes 0, 1, 2, 3, 4 as their scores. Divide the counts of codes respectively by the total number of dental subjects examined and multiply by 100 to obtain mean number of sextant, that is MNS, for each condition per person. Divide the total number of sextant with higher scores of dental subjects examined. Now coming on to the CPI or cumulative periodontal index. It is a modification of CPITN. It was done by the inclusion of It is done by the inclusion of measurement of loss, attachment, and elimination of treatment needs category. The indicators are 3 indicators of periodontal status are used for assessment: gingival bleeding, calculus, and periodontal pocket. The probe used is a specially designed lightweight CPI probe with 0.5 mm ball tip with a black band between 3.5 and 5.5 rings and 8.5 and 11.5 mm from ball tip, that is CPITN C probe. Sextant are chosen from 18 to 14, 13 to 23, 24 to 28, 38 to 34, 33 to 34, and 33 to 43, and 44 to 48. Index tooth are for adult aged 20 years and over: 1716, 1126, 27, 3736, 3146, and 47. The two molar in each posterior sextant are paired for recording, and if one is missing, there is no replacement. If no index teeth is present in a sextant qualifying for examination, all the remaining teeth in that sextant are examined and highest score is recorded as the score for that sextant. Of in this case distal surface of third molar is not scored. For subjects under the age of 20, only 6 index teeth are examined up to the age of 19. That is 16, 11, 26, 36, 31, and 46. So this modification is done in order to avoid scoring the deepened sulci associated with eruption as periodontal pocket. For the same reason, when children under age of 15 are examined, pocket should not be recorded. That is, only bleeding and calculus should be considered. So sensing gingival pocket and calculus and index tooth should be probed using the probe as a sensing instrument to determine pocket depth and to detect subgingival calculus and bleeding response. When probe is inserted, the ball tip and should follow the anatomic configuration of the surface of the tooth root. Probe tip should be inserted gently into gingival sulcus or pocket, and the total extent of the callus of pocket, and the total extent of the slouch of pocket and spine. The probe is placed in the pocket and the distobuccal surface of the second molar as close as possible to contact point with the third molar, keeping the probe parallel to long axis of teeth. And the probe is then moved gently with short upward and downward movements along with the buccal sulcus or pocket to medial surface and second molar, and from distobuccal surface to first molar toward the contentile area of the premolar. So examination, the highest after the examination, the highest score is recorded in the appropriate box. If you score 0, it is the tooth is healthy. Score 1 means bleeding observed directly or by using a mouth mirror after probing. Score 2 is calculus detected during probing, but all of the black band on the probe is invisible. And pocket score 3, pocket 4 to 5 gingival margin within the black band or on the probe. Score 4 means pocket 6 or more. X means excluded or less than 2 teeth present, only one tooth is present. 9 means not recorded. The loss of attachment, information or loss of attachment may be collected from index teeth in order to obtain an estimate of the lifetime accumulated destruction of periodontal attachment. This permits comparison between population groups, but it is not intended to describe the full extent of loss of attachment in an individual. So the highest scores from CPI in loss of attachment may not be necessarily be found on the same tooth. Now, loss of attachment should not be recorded for children under the age of 15 because of presence of pseudopockets. The probing depth less than 6 any loss of attachment for that extent is estimated to be less than 4 Loss of attachment score is 0. Criteria for loss of attachment: 0 means loss of attachment is 0 to 3 0.3 0 to 3 that is CJ not visible and CPI score is 0. If the CJ is visible on the CPI score is 4, or if CJ is visible. Loss of attachment is 4.54 to 5 under the black band, that is score 1. Now the second point is loss of attachment 6 to 8 Now point 3 is loss of attachment is 9 to 12 and fourth score is loss of attachment up to 12 and X is excluded less than 2 teeth present, and 9 not recorded, neither visible nor detectable. The conclusion is periodontal index can be used in epidemiological surveys. More data can be assembled using PI than any other index of periodontal disease. PI is useful among large population but is of limited use for individual or a small group. Periodontal disease index is suitable for longitudinal studies of periodontal disease. CPITN index attempt to control periodontal disease and promote good periodontal care, and reason behind this is improve quality of life, enhance general well-being and appearance, reduce halitosis, elimination of bleeding from gums, and improve mastication. Thank you.